I invite us to, for a moment, enter the space of global health. And in particular, let's start with global health aid. The amount of money that's being spent for global health aid by wonderful organizations is approximately $50 billion a year. $50 billion a year. So at the last 5 years, that adds up obviously to about $250 billion, $250 billion spent on global health aid. I'm fortunate that I get to speak with a number of the leaders in that sector, and also a lot of academics that are devoted their whole life to it. And I like asking a question, which is, imagine any metrics of global health aid you care to imagine. Pick 10. And in your mind, rate the world today on those 10 metrics. And now in your mind, go back 5 years and rate the world using those same exact 10 metrics, or 5. Has the needle moved very much? How much have the needles moved in 5 years on those metrics? And the answer is always not very much. So I asked the question, you know what, before asking the question, let's say all of us in this room elected the top 10 people in this room to go away and figure out how to advance global health aid, and we gave them $250 billion to spend in the next 5 years, and said, what could you folks do with $250 billion? What can't you do? So the question is, how is it possible to be spending so much money and not to have many needles move at the end of 5 years? Hold that thought for a moment. In decentralized healthcare globally, now not the aid portion, which maybe applies to the bottom of the pyramid, so to speak, a couple of billion people, but the rest of the world. How much is spent on decentralized healthcare globally? By decentralized healthcare, I mean outside of the hospitals, so in clinics and health posts and those sorts of places. And the answer is about $5 trillion a year. $5 trillion a year is spent on decentralized healthcare. By the way, all healthcare globally, it's about $8 trillion a year, which is approximately 4 times the entire defense budget of all countries in the world. $8 trillion, the majority of it on decentralized healthcare. What is the quality of care in decentralized facilities on average delivered everywhere? I'm from Toronto. Ask the question of Toronto, ask the question in Tanzania, ask the question everywhere. And if you look really hard at it, it's not so great. You go to 10 or 15 different clinics with the same symptoms, and you may get 5 or 10 different ideas of what you should do. We all know this. The financial system, the $5 trillion, the healthcare system, is almost at the breaking point. Certainly it is in the United States, but really everywhere else. Always more money is needed. Another 3% on this $5 trillion is needed for this year, let's say. And yet, most estimates are that again, I'm focusing on decentralized healthcare, not hospitals, there is a significant amount of waste, perhaps as much as 40%. We've seen anywhere from 30 to 50%. So people are fighting to increase the healthcare budget by 3%, by 1.5%, and it's a terrible struggle because that's so much money. And yet there's so much that's being wasted. Something doesn't add up. If you took all of the healthcare data in this world and put it into a gigantic skyscraper, and you ask the question, how much of this data comes from decentralized facilities? The answer is almost nothing, about 5%. 95% of all healthcare data on planet Earth comes from centralized facilities, hospitals, and medical centers, because they have the technology and the time and the resources to capture the data. If you ask the question, how many people who see the healthcare system somewhere. You know, you see a physician, you see a health worker, you see a nurse. Count all those up. What percent of that number comes from hospitals or occurs in hospitals? And the answer is about 5 to 10%. So 95% of all healthcare data is captured where less than 5 to 10% of all healthcare interactions occur, which means where 95% of healthcare interactions occur, there's almost no data that's systematically captured. Show me a system, any kind of system, that doesn't have data to provide feedback loops, and I'll show you waste, and all of a sudden the 30 to 40% waste, which sounds astronomical, is actually quite understandable. So in decentralized healthcare, we don't really have substantial amounts of data. By definition, since it's decentralized, it means the health workers who are delivering the care have their supervisors who can guide them elsewhere, so that there's no tracking and there's no guidance. I say no, but it's mostly that. Because there's no data, there can be very little insights gathered from all of these healthcare interactions. And so the insights that would create quality, that would create accountability, that would create efficiency are missing. The system operates without the circulation of insights. And you have a massive system affecting hundreds, well, really affecting trillions of dollars, billions of people, that in the decentralized portion, whether it's in Toronto where I live or anywhere, is operating without the benefit of automated data capture and data injection back into the system to assure a certain level of quality and efficiency. I now want to describe a technology or technology class, not a particular technology, because technology can and must address this problem. It is related to IT, but it is not just IT. It's the fusion of IT with care delivery technology, so that it is a whole. It is a technology that guides the delivery of care while automatically capturing data, extracting insights, and adjusting the delivery of care. So the technology consists of a series of AI-powered, machine learning capable, smart devices in the hands of health workers who are delivering care. Also capable of uploading all of the data via any local cell networks, cloud services, web portals that allow other stakeholders to interact in the system, and finally, connectivity technology that allows the devices at the point of care to be integrated with other technology that's there, and that allows the data to be integrated with other healthcare information systems and other kinds of databases globally. So it's 4 kinds of technology, and it works like this. And I'd like to explain one point. Why is it that decentralized healthcare doesn't capture data? It's not that it's not needed. So why would it be? And the answer is that if you have a health worker, if you picture a health worker in a very busy clinic, unlike in a hospital, you will see 1 or 2 health workers and hundreds of patients that are that are pressing to be seen. And so at the end of the healthcare interaction where the health worker delivers healthcare, they have a dilemma. They either somehow capture what just happened, or they go on and see the next patient. They are always encouraged by the need to go on and see the next patient. And because the data wasn't captured at that moment, it's lost to the system forever. So we have this very complicated problem boiling down to a competition in the form of a health worker, and the competition is between care delivery and data capture. So let's build a technology that eliminates the competition and actually has care delivery drive data capture and data drive care delivery, using the four components I mentioned. So now picture this health worker with a device. The device has in it the expertise of clinical protocols, what questions to ask, based on the answers, what questions to ask next. Very little typing should be involved, in fact next to none. It should be very icon driven, it's touch screen. All the possible answers that a patient may give are on the system and on the device, and the health worker touches the correct answer. It navigates to the patient, to the next question. High quality on-the-spot blood or urine or sputum testing can be performed using the same technology, so that the level of accuracy of the technology is equal to, maybe 99.5% equal to, the level of accuracy that will be obtained in a laboratory. But now it's on the spot. As the patient walks out the door, because the health worker was constantly touching the device to navigate through the healthcare process, the data is uploaded to a database from which remote supervisors, maybe sitting in a cafe, sitting in their office, can open a tablet or a laptop, configure Windows, a dashboard to their heart's content, as many as they like, and the system automatically populates it, ranging from information about the patient, information about tests and drugs consumed, actually information about the workflow of the health worker. Every aspect of the interaction is timed. The supervisor remotely sitting can also interact with the system and communicate whenever they want to with the health worker. So there's an automatic intervention that's possible. Half of the supervisor's job is supervising, the other half is actually reporting. They can figure as many reports as they like to the stakeholders that they authorize, and those stakeholders, when they open up their tablet or laptop, can instantly see, in real time, auto-population of their dashboards. So that the insights that are captured are disseminated to stakeholders. The results of doing that, and all what I've really described, boils down to extracting data on the spot from healthcare processes that are unfolding, extracting insights from those healthcare processes and disseminating them, and injecting the insights, sometimes automatic, sometimes by a push from the supervisor, right back into the healthcare processes. The results are 10-fold reduction in diagnostic errors over 5 weeks. 10-fold increase in compliance with the clinical protocols that the health workers are supposed to be following, but it's so difficult to follow when you've got so many patients and you may be a little confused in one patient to another. So 10-fold improvement in compliance, 50-fold increase in accurate epidemiologic information, and easily a third reduction in waste. All because a competition between data and care delivery was turned into a synergy of data capture and care delivery, allowing the circulation of insights. To be very practical, one has to look at the economics. At a macroeconomic level, what I'm talking about makes sense, but the problem is nobody makes macroeconomic decisions. Decisions are made at the programmatic level, so look also at the microeconomics. So let's say there's a $100 million healthcare program. Call it 5 years. Using the information we've talked about so far, there's probably 30% waste easily in that system. Suppose instead of spending the $100 million on every dollar of it on drugs and tests and health other kinds of health delivery technology, we took 5% of it, $5 million, on feedback and guidance technology, which means there's $95 million left for the program. If we eliminate just half the waste, which is $15 million, after paying for the care, the guidance and tracking system, that leaves an extra $10 million. So by spending, which adds up to 105, actually we've seen an elimination of about 30%, so double those numbers. But even at these numbers that are half, by spending 5% of your healthcare budget on non-healthcare items, but rather feedback and tracking, you're actually enabling, by the elimination of even half the waste, 105 million, 5% more than you were spending before on the delivery of healthcare. This is not magic. This is actually just a natural law. The problem is that the healthcare systems that we've evolved are missing the natural law of feedback and automatic injection of insights to govern the processes that the healthcare system is undertaking. So the opportunity today is to use technology to bring back very natural processes that are intrinsic to any organic system, such as healthcare. Thank you.